think that's us live, Loreena, so I think we'll start.
Okay.
Hello everyone, you're very welcome to the third session of the European Journal of Cardiovascular Nursing's Journal Club. My name is Donna Fitzsimons. I am a past chair of the Council of Cardiovascular Nursing and a member of the editorial board. But I'm here this afternoon to speak to Loreena Hill, who is the author of the paper that we'd like to discuss this afternoon, the Implantable Cardioverter Defibrillator, Deactivation Discussions, Reality versus Recommendations. You're very welcome, Loreena. How are you?
I'm very well, Donna. It's nice to speak to you.
Okay. Would you just like to give a little bit of background, Loreena, to yourself before we begin?
Okay, pleasure. So a wee bit of background regarding myself. I've worked for the past 10 years as a heart failure nurse within a regional implantation centre here within Northern Ireland. My role and my experience of managing these end-stage heart failure patients, particularly those with an ICD, is quite clinically challenging. And really, in 2012, I met a very inspirational lady who had end-stage heart failure. She also had stage 3 kidney disease, in addition to other comorbidities. And it was this lady that really inspired me to look at this subject in more depth. As she questioned, because she was end-stage, she questioned the role of her ICD. And working in the area and seeing these patients daily, I wanted to make sure that my clinical practice was evidence-based. At that stage, her ICD, she wanted to be deactivated, but there was limited European evidence at that stage, which prompted me then to commence a PhD in 2012. And this article really outlines the findings from one element of this study, and it's the retrospective case note review element.
Okay, and what were you hoping to achieve, Loreena, in that retrospective case note review?
I wanted to examine what the current clinical practice was within Northern Ireland, and really look at the decisions that are being made for this sample of patients with an ICD from their implant to final documentation and death. So I really wanted to know what was happening now within clinical practice.
Okay, so could you tell us a little bit more about the setting in which you conducted this study? What type of hospital is it?
So the hospital that I was a heart failure nurse and still am a heart failure nurse in is a large, very busy regional implantation centre. They would implant between 250 and 300 ICD or biventricular ICDs annually. And it's quite within this, it is a small population. Northern Ireland's not a big country, and it would be one of the main centres within Northern Ireland to both implant and then manage these type of patients.
Okay, so it has specialist heart failure nurses there, I presume.
Oh, absolutely.
Yeah.
Absolutely. In total, there is currently 5 heart failure nurses working at that stage, working in the trust.
Okay, well that's a very helpful background, I think. Now, I would like to invite other people who are online to potentially ask us some questions about the paper. You're very welcome to type your comments, and we will try to incorporate them on the little chat message at the bottom right-hand corner of your screen, and we'll put those to Loreena and we can have a chat about the paper. So any input we have from colleagues out there who are listening to this would be very welcome. So just to think about this study then, Loreena, what was your real purpose in undertaking this as part of the programme of work that you were doing at that time?
Okay. So, as I said, I started my PhD in 2012, really looking at quite an exploratory study, looking at the perspectives of patient carers and professionals. And two other elements. First element was a very qualitative approach, where we really got a really in-depth understanding of the perspectives of patient carers and professionals. The third element was a factorial survey, which was a survey sent to professionals. So, but this second element really was what gave us our strong foundation or baseline of what was happening in clinical practice currently. What were the decisions that were being made by practicing clinicians, and how were they making those decisions? What were the main indicators that we could identify through the medical case notes and the retrospective medical case notes of how they came to make those decisions, and sort of help allowing that then to hopefully inform then the PhD study.
Okay, that's excellent. So tell us a little bit about your sample then. You looked at over 50 case notes. So tell us a little bit about the profile of that sample to begin with.
Okay, so we decided to look at the number of patients who had died over a 12-month period, and we identified that there was 59 patients had died during a 12-month period from 2012 to 2013, and that time frame was chosen in line with my study. We identified 59, but due to medical legal reasons, we were only able to retrieve successfully 44 case notes. And when we looked at those case notes, these related to quite a significant proportion of male patients, and there's a table in the article which really breaks down the sample. There's quite a proportion of males. They were aged roughly in their 70s, and there were their devices had been implanted both for equally primary and secondary prevention.
And sorry, Loreena, just to pick up on that, whenever you say that there was there was a proportion that you weren't able to find their notes for medical legal reasons, what kind of things could that be?
There was some that unfortunately we were able to retrieve because the patient had died suddenly, and they may be going for post-mortem, and the notes had gone there, and there were some that we just weren't allowed to retrieve because of legality reasons, unfortunately. Okay. So and certainly those may have had a bearing, but we successfully retrieved 44.
Okay, so this is a fairly typical ICD population in terms of the age, the gender, and those other sorts of characteristics. Do you think it's a fairly representative sample?
Basing looking at the sample and reflecting with other ICD studies that have been carried out in Sweden and in America, it would be quite representative in that, as we know, most there's more males would have an ICD implanted than females, and it seems to be most of the devices are implanted usually in the 70-year-olds, or have most of the people in the 70-year-olds.
Okay, and a nice even split between primary and secondary reasons for implantation. Okay, so let me talk you through your study then. Whenever it came to seeking approval for your study, where did you get ethics approval? How difficult was it to get ethics and governance approval for a study of this nature?
It was quite difficult. We first of all, for this part of the study, it was approved by the university filter ethics committee, and they approved the study, and then we needed approval from the trust to access the notes, and that was quite an arduous process. It was one element of my PhD, which we were gaining ethical approval for the three elements, and because we were also interviewing some patients, the process was quite challenging because it were recognised as quite a sensitive population.
Okay. So tell us a little bit then about how you approach data collection. I see that you used a standardised protocol. Were you able to derive that from other studies that have been done in this area, or did you need to, develop it specifically for this study?
This one that I use, which is attached in the appendices, for really anybody else, was developed by myself, really reflecting on other studies that had been done and the data they had collected, which I also thought would be interesting to find out. In addition, from studies such as by Goldstein, and also recognising the importance of validated questionnaires such as the Seattle. It was the protocol that was developed was developed by myself just to standardise the data collection, and also because I wanted to, in maybe a few years' time, if it required to repeat the process, I would have a model in which I could just go back and reevaluate if there's been any change following the dissemination of my results.
Okay, and if other people wanted to use that protocol, is that available to them freely? Can they do that?
Yes, I attached it on the end of the article in the appendices, so I'm quite happy for anybody to, if they feel it of value, or to adapt it appropriate to their needs. There is, there is some things I may adapt in it, but I certainly found it extremely useful to standardise the data that I was gathering.
And that would be kind of interesting as well, wouldn't it, to see how practice within your setting compares to other European settings. I'm sure that is an important consideration at some point, just to compare practice across different countries. So can you tell us a little bit about the data collection then? How difficult was that process? Did you need, how hard was it for you to do it, and did you come across any particular obstacles that you could, tell our readers about to potentially help them?
Okay, it was an enjoyable process. It was more time consuming, I would say, more than anything else, in that if you take one patient who had maybe their ICD for maybe 10 to 15 years and they were being reviewed for a number of comorbidities, if you can imagine, some of these patients had between 4 or 5 medical charts attached to them. And then it was a matter of literally going through each of the charts quite carefully, because I wanted to collect data from the time of implant right through to death. So I wanted to check that any professional had ever broached the discussion of deactivation before. So it was a matter of both looking through all of their medical charts. In addition, within the regional implantation unit, they have an electronic database. And just to completely validate the medical records, I also looked at the electronic database results, just to see if there was any information that I may be missing from the medical notes. So it was certainly time consuming, but it did provide some very valuable results.
So I get a sense of you sitting sort of knee deep in clinical files. I guess that tells us also that these people are quite complex, with a lot of comorbidities and maybe fairly protracted clinical episodes in hospitals. So collecting that, actually sifting through that volume of information, I'd say, would be quite challenging, I'm sure. Was it?
It was because you were reading every consultation that they had to see if it wasn't a cardiologist review. Maybe they had a renal physician. Did they broach it? Maybe they were diagnosed with a cancer diagnosis. So you're looking at their an oncologist. Did they mention anything about the device? And you were nearly hoping at the end of it that somebody did, so you were literally anticipating some sort of results, but at the end of the day, by clearly saying that if the discussion did not happen because it was not documented.
And that was the case in most of your 44 patients, isn't that correct?
absolutely, which was quite surprising as a clinical heart failure nurse working in the area at the time, in that it was concerning because it was black and white evidence, and that was concerning. And it was something that you assumed somebody would have done, but obviously through the case note review we could clearly see there was no documented evidence of a discussion, most patients having a discussion.
So whenever you say you would assume that that discussion would have taken place, why would you come to that assumption, Loreena?
I suppose at that time I had, as I said about my background with the pleasant lady that I met, I was aware there was clinical guidelines out there which clearly said that there was a number of points throughout the patient's journey, if they had an ICD, that ICD deactivation should be discussed. And I assumed, which again is incorrect of me, I assumed at some point somebody would have mentioned it, but particularly prior to implant or if their condition deteriorated. But as you see from the results that I obtained, most of the discussions happened when death was clearly imminent, and unfortunately we found that most of the discussions occurred at that time of a median 10 or a median of 7 days prior to death, was when most of these patients first of all had not only ICD deactivation discussed, but also when they were having an end-of-life discussion regarding their prognosis as well. And these, when we looked at the patients, these patients not only had heart failure, but they also had quite a number of other comorbidities. Some of them had cancer and some of them had chronic kidney disease. So they, as you said, they were complex patients.
Yeah. So the fact that the median time to discussion of ICD deactivation for those patients who had that discussion was 7 days, that's somewhat concerning, isn't it? So people have in the last week of their life to consider quite difficult decisions if this topic has not been broached previously with them. Would that be a fair assumption, fair conclusion, do you think?
Oh, very much. They have a lot of, when we looked at it, the discussion, I collected data looking at what types of topics were discussed during that end-of-life discussion. And the topics that were most likely to discuss was prognosis, continuation of fluids or IV drugs, and ICD deactivation or combination of all of the three elements. And most of the end-of-life discussions did include something about prognosis. So when death was imminent, professionals were quite happy to, or not happy, were happier to discuss prognosis. However, even at that quite imminent death, even at that point, ICD deactivation was still a difficult topic to bring up, as we've seen in that 23 patients had a discussion, but only 17 of them actually had their device discussed as well. So there's something clearly about the ICD that professionals feel are reluctant to broach even when death was imminent.
Yeah, so that is quite, again, an interesting perspective, isn't it? And it tells us a little about how difficult such conversations are for clinicians. One of the facts that struck me in particular was that in only one case did you find evidence of a specialist heart failure nurse actually having that discussion. Is that surprising to you?
It would be, particularly working as a specialist heart failure nurse. It would be, because we do see a lot of these patients quite regularly, and we would have probably more opportunities than the clinicians to review these patients, and we often build up that supportive relationship with them, and both the opportunities and that relationship, you would think, should allow us to have those more open discussions, or sort of be more aware of when a patient wants to discuss issues such as this. I think we often feel that as a nurse that this is something that whoever implanted it, either the electrophysiologist or the cardiologist who's looking after their care, this is their decision and this is that will not do anything about it until the cardiologist broaches it first. However, clinical guidelines are not just for clinicians, and they're also for us to implement as well. So whenever I was finding the results, it also not only really sort of progressed my ideas of research, it also really made me think of my clinical practice as a heart failure nurse and how that could definitely be improved.
Yeah, that's very interesting, and I think we'll something that we will no doubt come back to in the discussion, because I think that's interesting, and I think it's interesting for those of you who are listening out there as well to consider, would that be normal part of your practice? And we'd love to hear about that if other people would like to tell us if these kind of findings could have come from your hospital setting, your clinical setting. We would certainly be very interested in getting your feedback. If you are having any difficulty sending that to me online, you can email me on d.fitzsimons with one M, so that's FITZSIMONS at ulster.ac.uk. And we certainly would love to have your contribution to this call this afternoon. So, Loreena, 16 of the 44 patients actually had their device deactivated. Does that surprise you?
It does, because it's quite still a very low amount, and out of the 44, so not even half of them had their device deactivated. I presume it would be a lot more, but unfortunately, no, it wasn't. When the most interesting factor of those ones that did have their device deactivated, when we did our statistics, we noticed that more patients had their device deactivated if they had not received a shock. And that was quite interesting, in that the guidelines would say that ICD deactivation should be considered if the patient is having multiple shocks, but for some reason within clinical practice there's more likelihood for a device to be deactivated if the patient has had no shocks. And that's something which I was sort of finding difficult to explain, particularly within clinical practice, was it the fact that they felt more reassured that the device was not being proactive with the patient, that they were more happy to deactivate it rather than...
And let's talk about that a little bit more, because the fact actually that the device has a history of shocks shows that at an end of life stage, presumably it would be more likely to activate. It would be more likely that the patient would require defibrillation, and so I get a sense that could mean that people who are having an otherwise normal, peaceful, perhaps death, would receive shocks to prevent that from happening. Is that your understanding of it as well, or your interpretation?
What was that again? Sorry.
So is that what you think is happening, that potentially those people who who need the device deactivated most, actually the ones who are more likely to be shocked in their end of life days and hours, are actually those least likely to have the device deactivated?
Absolutely. It is those ones who have a previous history of receiving quite multiple shocks, that were had their device kept active, and out of the 23 end of life discussions, 17 of these patients where ICD deactivation was discussed by the clinician with the patient, and only one of those patients, despite ICD deactivation being discussed, refused to have his device deactivated, and he died with his device active. So by having a discussion does not readily associate with the patient automatically agreeing to having the device deactivated. However, it's the patient needs to be knowledgeable and be able to make that informed choice. And just going on looking at the other parts of my PhD study and looking at the literature, there is a lot of evidence to say that a lot of these patients feel quite secured and feel their ICD is a lifesaver, and really to have a clinician then come along when they are in a very vulnerable state, when death is imminent, and basically the clinician says to them they want to deactivate this device, which they have basically had a lot of security in for quite a long time, may just be too much for them at that time. So, you know, I can see why that gentleman, or whoever it was, decided, no, I want the device kept active.
And just to follow on from that point, from those 16 patients who had their device deactivated, the recorded mode of death for only 4 of those was sudden cardiac death. So from that, I would assume that, you know, while, as you say, people traditionally assume that the ICD is there as almost a life support, in actual fact, only about a quarter of these people went on to have a sudden cardiac death, and presumably the others died from other causes. So is that what you would assume as well?
Certainly, with only the 4, a lot of these patients had heart failure, so a lot of them would have died from a progressive pump failure, more so than actually the sudden death as a result would show. However, even though that may be, it doesn't mean that their device may not have activated at some point. And there was a study carried out in Sweden, and it did show that quite a significant number of these patients, when they interrogated explanted devices, did show that these patients, even though it did not appear clinically they were having shocks, a lot of these patients did receive shocks at the end of life. So even though 4 were certified as having a sudden death, we can't exclude the fact that if they had an active device, that they didn't experience any shocks while they were dying.
Yeah, that's quite interesting. The other nuance within that data that I thought was quite interesting was that, you know, for 17 of the 23 patients where an end-of-life discussion was documented, deactivation was associated with that. What do you think happened with the other 6 patients who there was no deactivation associated with the end-of-life discussion?
That would be an interesting, unfortunately, it would be one of those interesting findings where you're questioning what was discussed. In those discussions, the topics that were covered again were prognosis, or continuation of IV therapies and continuation of IV medications. And it may be that the clinician did not actually appreciate that the patient, number one, had a device which could cause could cause the patient difficulty at the end of life, or didn't realize this was something that needed to be deactivated. And we did also find that some of these patients had DNR discussed, or do not resuscitate order, and we find that that was associated more so with a device deactivation topic. So maybe that clinicians, professionals don't actually realize that if the patient is at the end of life and they are having a DNR order, that should run an active device. If the patient has an ICD and it is active, that still is an active treatment that they're receiving. So I think there is certainly something about knowledge, because the case note review not only examined practice within cardiology, but examined practice within general medical wards, general surgical wards, and these are professionals who may not have day-to-day experience with patients with an ICD, and they may not actually realise the functions that the ICD will bring.
Okay, that's very interesting. Actually, fascinating. We could, begin to discuss that a lot more, I would imagine. But then, the major part of your analysis was around looking at the factors that were associated with ICD deactivation. Do you want to tell us a little bit about those, Loreena?
Yes, we found, as regards to ICD deactivation, one of the main things was that they were very close to death. The patient was, as we said, within about median time of 7 days prior to death. Other factors that were associated was their age. Other factors was comorbidities. We found that a lot of these patients had a cancer diagnosis as well. Interestingly, the referral to specialist palliative care was not associated, or referral to hospice care. But as I've already mentioned, a DNR order was associated with ICD deactivation.
And was there anything in and around those factors that surprised you as a specialist heart failure nurse? We've already, not the ones we've already discussed, but in addition, or was that?
I think possibly the hospice referral to a hospice or referral to specialist palliative care I would have presumed would have prompted a discussion about device deactivation, as obviously that within the case notes it was very much that these patients were palliative. So these patients were being referred to specialist palliative care. They had clear indicators. The professionals clearly were aware that these patients were now palliative. However, still, contrary to the guidelines, device deactivation wasn't discussed. The European and American guidelines would say that there's a number of stages throughout the patient's journey it should be discussed. One of them being prior to implantation, the other one being when the condition deteriorates. And surely, if the condition deteriorates and the patient's indicated to be palliative, then a discussion should have been had. And then the third case would be when death is imminent. So there was two clear points along the patient's journey that a lot of these patients, the device deactivation hadn't been discussed.
And that kind of prompts me to think about the editorial that Meredith McKenzie has written on your paper, really, because I think it says, magical thinking around end of life, and she really focuses on the inevitability of death and yet our reluctance as a society and as clinicians to discuss that. And that really brought it home to me really clearly that these are difficult conversations, and even for practicing very experienced clinicians, it can be really challenging to engage in these discussions. Is that something you've found in clinical practice or in the literature to be the case, Loreena?
In both cases, both in clinical practice as a heart failure nurse, is very difficult, and you are waiting for patients to give you those indicators that they're ready to have those conversations. And I think doing this study has made me a lot more aware of the need to maybe be more conscious of those indicators and maybe prompt rather than not always waiting for the patient, because a lot of it can be that the patient's not aware that they need to ask. So we're waiting for a patient to ask questions on a topic they do not know that they need to ask about. So it certainly has made me more aware of that, of sort of asking patients, are they, even questions such as, are they aware of the functions of their device, to see if they're aware that it can actually be deactivated. certainly within the literature, there is lots of studies throughout Europe and in America which would say the case.
Yeah, so it's this thing about shared decision making and courageous conversations, isn't it?
Yeah.
That is, has really been a key feature in the literature in heart failure for a number of years. So I think that you've certainly made a contribution to that in this paper. And can I ask you about finally then, when you look at this and you look at the sort of the opportunity to implement evidence-based practice and follow the recommendations given to us in guidelines from the European Society of Cardiology and other groups, what would your conclusion be here, Loreena?
I think there certainly is work to be done in the implementation of the guidelines, as well as that, particularly as a nurse, and the guidelines are there for multi-professionals, not only just for clinicians but also for ourselves, particularly if we're working as an autonomous heart failure nurse who is building up relationships with these patients. We need to be implementing we need to be practicing giving evidence-based practice, and that very much is looking at what are the guidelines. We do that then daily regarding our medications. We're titrating medications in according to guidelines. We're giving self-care management information according to guidelines, and this is an extension of that, in that there is clear guidelines regarding the management of end-of-life care of patients with an ICD, and it's something as a heart failure nurse I feel that we should definitely, it's a challenge, but it's something that I think we have a massive contribution to play, and certainly not just the decision-making process, but clearly the discussion that we are regularly seeing these patients, and there is opportunities for us in a very tailored approach, in a very concise approach, and very much given the patient individualized information, but certainly there is a place for us to contribute to really improving this area.
That comes across very clearly, and I suppose it links in with other work that I'm sure you're aware of in the Council of Cardiovascular Nursing, which would have been around nurses' involvement in guideline implementation, because you're based in the UK, where as a heart failure nurse specialist you have prescribing authority and a lot of autonomy in terms of patient care. But within Europe there's a lot of variation in heart failure care and the role that nurses have in that. So are you aware of the CCNAP toolkit that has been developed recently, Loreena, and do you think that this would have any role in making sure that nurses get the support and the education that they may require to make sure that their practice is more evidence-based?
I was aware of it. I attended Euro Heart Care last year in Dubrovnik, and basically I had the pleasure of watching some videos regarding the implementation of the guidelines and how they should be implemented, and the scenarios that were portrayed. So yes, I'm very much aware of the work CCNAP are doing. As regards sort of, is there a role to play and for that in helping nurses across Europe? Yes, I do think there is. I do think that the toolkit should help quite a lot. And I think it's a matter of nurses sort of being aware that this is something that they really need to take on board, and this is something that they have a responsibility for their patients to take on board. And yeah.
So that toolkit, for those of you who aren't aware, is available on the CCNAP page on the ESC website. And then just to finally ask you, Loreena, you took the decision to publish this paper in the European Journal of Cardiovascular Nursing I noticed that you've published papers elsewhere in the past. I think this might be your first European Journal of Cardiovascular Nursing publication, and I would just like to know why you chose that journal and how you felt about the actual publication process.
Absolutely. This is a very prestigious journal. The European Journal of Cardiovascular Nursing is a very prestigious journal. It is widely distributed and read throughout Europe by nurses. It's very highly ranked in terms of its science. It's ranked 9th for science. So I knew that any articles that were published by this journal was going to a very well expert audience. The review of the journal was the process was quite quick. The reviewer comments that I got back, peer review comments that I got back, were very constructive and very informative, and I really felt that they strengthened the article and made me go back and look again at my data and hopefully make the article a lot stronger and a lot more applicable to the readers that were out there.
Okay, well, Loreena, thank you very much for your contribution today. I think it has been a very helpful insight into your paper and the rationale for it. And just if you could sum up for me, just the real take-home message from this paper, what would you leave people with as they go away from this paper, do you think?
I think that the real take-home message is that ourselves as specialist nurses must take on the responsibility of ensuring that our clinical guidelines are really implemented within practice, that these patients that I found really had those very sensitive and difficult discussions left too little too late, a median of 7 days before they died, or very much not giving them enough time to plan and make any advanced planning for their demise. So I would say that it was just the conversations like device deactivation need to be implemented and need to be carried out a lot sooner rather than what is currently being done.
Okay, well, too little too late sums it up very nicely, Loreena, I think, and leaves us and leaves me, and I'm sure no doubt those people who are listening, with a very thought-provoking message for clinical practice. So thank you very much for your contribution.
Thank you.
And good evening.
Thank you, Donna. Thanks.